Hi, this is Judith Karaksoni and Manos Berlakis, and this is case 173 for the Manual of CTO Interventions. This is a case illustrating some of the difficulties when deciding when to stop a CTO crossing attempt. The patient presented with exertional chest discomfort that was refractory to medications. He did have a previous coronary bypass graft with 3 bypass grafts, 2 of which were open, the lima to LAD and the vein graft to obtuse marginal. However, the vein graft to the right was occluded, and he did have a mid-right coronary CTO with inferior ischemia and a normal ejection fraction. This is a coronary angiogram, dual injection, showing a CTO of the mid-right coronary artery, close to the takeoff of an acute marginal branch. The right posterolateral and the PDA are filling through an epicardial collateral. There is diffuse disease distally, and at this point is likely the area where the bypass was anastomosed to the posterior descending artery. So we have a CTO with a blunt proximal cap, length of approximately 50 millimeters, diseased distal vessel. There's a bifurcation close to the distal cap, and then it is filling through epicardial collaterals that appear to be small with significant tortuosity in their early segment. So our plan here was to try with Antegrade wiring. If it didn't work, try with wire Antegrade dissection or reentry. And if that didn't work, potentially explore the option of a retrograde through the epicardial collaterals. So we did Antegrade wiring. We tried the pilot 200 through a corsair that was unable to penetrate the proximal cap. We escalated to a more powerful penetrating guidewire, a Horner 14, then went down to a Gaia second and then a Gaia next one, and that allowed entry into the occluded segment. And then we switched for a polymer jacketed wire. This is a pilot 200 that seemed to knuckle distally. And then we used a Gladius Mongo, which actually did form a fairly large knuckle, but it did seem that the wire was dancing in sync with the distal right coronary artery. So we changed for a Stingray balloon, and we did the double-blind stick and swap technique with an Astato 20 and a Gladius Mongo and a Pilot 200 for the swap. However, unfortunately, we were unable to get into the distal true vessel. As you can see here, the wire is actually going in a different plane, suggesting that we may actually be in a side branch, early PDA or high acute marginal. We tried to reposition the system. We tried to knuckle again the wire, and again it seems to be going into a different plane. And despite multiple attempts to redirect, we did not have success, including here. We seem to be close. This is a Sasuke dual lumen microcatheter, but again, we had a hard time getting a wire to go next to the course of the distal right coronary artery. We decided to try a retrograde crossing through the occluded saphenous vein graft. We did have a nice, well-defined proximal cap. And that ended up being a fairly difficult to penetrate graft. We ended up having to use a Hornet to penetrate the proximal cap. Then we changed it for a polymer jacket, a Pilot 200 and a Gladius Mongo. And that made some progress through the proximal portion of the saphenous vein graft. But then in the middle portion, the wire was knuckling, was not going in the direction of the graft. And it appears that we were into the subintimal space into the bypass graft. So we decided to not pursue additional attempts for going through this saphenous vein graft. We explored the options for going retrograde through the epicardial collateral, but it appeared to be too small and tortuous, and we decided to not use it. What to do next? We decided that our only other option would be to try again to redirect the wire to see if we can get the Antegrade wire to go into the plane of the distal right coronary artery. We used a dual lumen microcatheter. We started the attempts fairly high in the mid-right coronary artery in an attempt to go more posterior in the course of the vessel. But again, despite multiple attempts and multiple guide wires, we did not seem to be able to get there. And when we did a gentle injection, there was actually some contrast staining in that area in the distal right coronary artery. We can see here that there is a space that is filling with contrast. Fortunately, most of the contrast is staying there and it's not clearing, but this was not promising. So we did have a perforation distally. We knew that we were into the architecture because we had flow through the mid-right coronary artery and then through this distal acute marginal branch. But we decided to not pursue any further attempts. We inflated a balloon for several minutes. We did an echocardiogram that did not show any significant effusion. And then we decided to stop. We removed the equipment and gave protamine. Fortunately, the patient did well. Here is the report from the echocardiogram and the CT scan. We did a CAT scan because sometimes loculated effusions can happen in patients with previous coronary bypass that can be lethal by compressing cardiac chambers. This is a CT done immediately after the procedure, showing some air and contrast, a small contained pericardial effusion. And then here is the echocardiogram, showing maybe some trivial inferior pericardial infusion, but there's no compression of the chamber. The ejection fraction is normal. The IVC was partially collapsing as it was doing before, and the same was seen the day after the procedure. Once again, no pericardial effusion, normal function, no compression of left atrium or any other structure. So in summary, this is a case in which the common saying of trusting the knuckle did not actually pan out. Here we did knuckle the guide wire, but somehow it did not follow the pathway of the right coronary artery. It is hard to know exactly why that happened. Our best guess is that it entered into a small side branch that did not become appreciated, and that potentially caused that contained perforation distally. Once we failed into the Antegrade ADR attempts, then we tried retrograde through a bypass graft. Occluded bypass grafts can be used for retrograde attempt, but here, once you have the subintimal or extra plaque entry of the wire, we decide to stop the attempts to minimize the risk of perforation. When there is a perforation in previous bypass patients, there is the risk of loculated effusions. Sometimes the echo may not fully appreciate this, and that is why we did a chest CT in this patient that showed a localized hemopericardium of small size. We did serial echoes, and we did not see any increase in the size of the effusion. Finally, regarding when to stop the procedure, having a complication is one of the reasons to stop the procedure, as is the exhaustion of the available options for crossing the CTO. In this particular case, we did not really have any other options for crossing the CTO apart from going retrograde through a tortuous epicardial collateral, which we decided was too high risk to undertake. So a complication along with exhaustion of crossing options is another reason for stopping the procedure. Thank you.